We've been responded to a 50-year-old male who's collapsed unwitnessed. Before we enter the scene, we want to make sure that there aren't any dangers, that there's good access and egress to the patient, and the area around the patient is clear. We want to make sure that we've got our PPE on, so we've got our gloves, our goggles and our boots, and so does my offsider. Before we go in, Gus, I just want to make sure that if the patient's cardiac arrest, that you go straight to the airway and I'll just jump straight on the chest. Clear?
Sounds good.
Awesome, let's go. So entering the scene, I can see that the patient is pale. Hi sir, can you hear me? No response to voice. Sir, can you hear me? There's no response to pain. I'm going to look, listen, feel for 10 seconds. Gus, can you call for R50 backup and turn the defib on?
81 to comms.
81.
Requesting a R50 backup for a suspected R49.
Cool, and attach the pad.
Roger, backup en route. Thank you.
Cool,
Thank you.
10 seconds.
Comms.
Start.
Backup's en route, 15 minutes.
Cool. He's in cardiac arrest. So attach the pads, and then once you've done that, we'll charge the defib.
Yep.
And check the rhythm.
Charging.
Cool, it's charged, staying clear, that's VT shock.
Shocking.
Cool, so can you shock the LMA in? So that was at 30 seconds. So the next one is going to be at 2 minutes 30. Put an LMA in, attach the entitled CO2 or COBS connector and the filter, and then attach the oxygen at 15 litres per minute. And then once we reach 2 minutes 30, I'm going to get you to jump on overhead compressions.
Cool, ready for our first two breaths.
3, 2, 1. Cool, perfect. Good chest, bilateral chest raise. So with the oxygen, we're rolling out hypoxia. We could also have hypothermia, but the patient is warm to touch, he's not wet, and he's inside.
5, 4, 3, 2, 1.
If there were any bystanders, which there aren't, I would be asking them any questions about cardiac history, anything about the patient and what medications they are on, if they have taken anything, to rule out toxins. There could be a thrombus, but we can't tell this until we get to hospital. Tension pneumothorax, we can rule out with any pressure to the bag mask, and also listening to the chest, which I will do.
Good. Breaths. 3, 2, 1.
So we're doing compressions at 30 to 2.
Cool, oxygen's on 15 minutes per minute.
Perfect. So we're coming up to 2 minutes 15, so once we're at 2:30 we'll charge again.
Yep, would you want me?
Yep, you're good. Okay, now, so charging. Everyone clear? That's still VT shock. Go straight back on, Gus. Cool. So keep doing 30 to 2. I'm going to do a trauma step to rule out any trauma or any hypovolemia. And so that shock was at 2 minutes 30, so the next one is going to be 4 minutes 30. So I'm going to rule out any internal bleeding, any external bleeding for hypovolemia, any trauma, which I can't see. On the next breath, I'm going to check underneath the patient, Gus. Come ahead. Cool, so no trauma. Checking underneath the patient. Cool, can't find any blood there. The next breath, I'm going to auscultate to see if there's good bilateral chest rise in both lobes.
2, 2, 2, 3, 2, 4, 2, 5, 2, 6, 2, 7, 28, 29, 30.
Awesome, keep it up, guys, doing really well. So we're going till 4 minutes 30, so about 1 more minute. So hyperkalemia, we can do a 12 lead, but we can't do that right now, so we'll probably roll that out if we get to hospital. Hydrogen acidosis we can't do until we get to hospital either. And thrombus is most likely at this age, but we're unsure. So Gus, on this next one, I'm going to charge and shock, and then you can shock, and then I'll jump straight back on, okay?
Yep.
So we'll go at 4 minutes 30.
Yeah, good, mate.
Also, we can can't rule out cardiac tamponade until we get to hospital. Cool, so I'm going to charge now. So charging, keep going, guys. Cool, so ready to shock. So that's asystole, we're going to dump it. Carry on, guys.
Switching 5.
Keep going. So switching 5, 4, 3, 2, 1.